So this will be a pretty quick overview of the drugs that we use in hypertension and some of the drugs that we use in other parts of nephrology. We're going to focus on the diuretics and the antihypertensives. So we're going to talk about the four classes of diuretics. We'll talk about angiotensin converting enzyme inhibitors, or ACE inhibitors. We'll talk about the ARBs, or angiotensin receptor blockers. We'll talk about the beta blockers and alpha blockers. We'll talk about the calcium channel blockers, and we'll finish up by talking about how we approach hypertension in pregnancy and where we expect to see that. So diuretics, there's four different classes of diuretics, and they all work on different channels in the nephron, so they all have different properties. But what they all have in common is that they increase urinary flow. They're also always contraindicated in pregnant patients, and we also like to always avoid them in patients with gout and lithium treatment. So the thiazide diuretics, hydrochlorothiazide is the drug that we prescribe most common, and hydrochlorothiazide is going to be your drug of choice in the average newly diagnosed patient with essential hypertension. So this is going to be the first drug you're going to go to. Assuming that they don't have diabetes, assuming that they don't have congestive heart failure in addition, assuming that they don't have any other problems that would relate to their essential hypertension, the first drug of choice that we're going to go to in a newly diagnosed hypertensive will be hydrochlorothiazide. Now, the way thiazide diuretics work is that they inhibit this NaCl channel in the distal convoluted tubule. That's going to result in more sodium being presented to this sodium-potassium ATPase. Now, if you see here, you've got 3 sodiums being pulled back into the blood in exchange for 2 potassiums being excreted out the filtrate. So the result of that is if you block this channel, and you're blocking it indirectly, you're blocking it because this NaCl channel is necessary for this sodium-potassium channel to function at a higher degree. If you are indirectly blocking this sodium-potassium ATPase, you're going to reduce the amount of sodium of ions overall being brought into the blood, because it's a +1 net ion increase into the blood. So the result of that is you're going to have more sodium and also more potassium in the filtrate. So this is going to cause a diuresis here. The adverse effect is hypokalemia, low blood pressure, and gout. So remember that thiazide diuretics can cause hypokalemia. Loop diuretics are also used for high blood pressure, but they tend to not be used as much as the thiazide diuretics. So loop diuretics are things like furosemide or bumetanide, and these are useful for patients with edema and congestive heart failure. This also plays a role in the treatment of milk alkali syndrome because it reduces the reabsorption of calcium. So loop diuretics inhibit the NKCC channel at the thick portion of the ascending loop of Henle. And so because you're inhibiting the NKCC channel, you're going to have more sodium in the filtrate. And that's going to result in more water in the filtrate and thus a diuresis. Because you do have more sodium in the filtrate and because you're going to reuptake more sodium, the result of that is you're going to excrete more potassium. So just like the thiazide diuretics, as you're presenting more sodium to this sodium-potassium channel, the result is that you're going to get rid of more potassium. The same thing with the loop diuretics, you're inhibiting the reuptake of sodium, so you're going to present more sodium to this channel in the collecting duct. And so you're going to have some sodium pulled back in, but at the expense of potassium. The overall result of both thiazide and loop diuretics, though, is a net reduction of sodium reabsorption. So it will cause a low reduction in blood pressure, but they will both cause a hypokalemia. So adverse effect of both thiazide diuretics and loop diuretics is that they cause hypokalemia. They also cause low blood pressure. That can be a desired effect or an adverse effect, depending on what dosage we put them on. And it can exacerbate or precipitate gout. The potassium-sparing diuretics work on the ENaC channel of the collecting duct. And what the ENaC channel is it's just a glorified sodium-potassium ATPase. So if you block that, you're going to block the excretion of potassium. And so what this is it's a way that we can diurese, but rather than diurese with sodium and develop a hypokalemia like the first two, we're going to diurese just with sodium alone. And so we retain our potassium, and that's why these are called the potassium-sparing diuretics. Because this has an adverse effect of hyperkalemia, and because that is so dangerous, we tend to not go to potassium-sparing diuretics as a first choice. So we will use these drugs in patients where there's significant edema, where we want to use two diuretics. But certainly we don't want to use loop and thiazide diuretics at the same time, because they both cause hypokalemia, and that can precipitate a massive hypokalemia. So what we do is, if we use two diuretics, we'll use a loop or thiazide diuretic in addition to a potassium-sparing diuretic, so that the hypokalemia adverse effect and the hyperkalemia adverse effect kind of cancel each other out. And so we won't develop a hypokalemia or a hyperkalemia. So when you see potassium-sparing diuretics, they're usually used in consort with another diuretic, a thiazide or loop diuretic. Because they also cause hyperkalemia, I don't have a picture of it, because they increase the amount of potassium in the blood, they will reduce the secretion of hydrogen. So they can cause a metabolic acidosis. So the adverse effects of potassium-sparing diuretics are hyperkalemia and metabolic acidosis. But we tend to use these most when we need to use two diuretics, and we use it in consort with a loop or thiazide diuretic. We can also use potassium-sparing diuretics in Little syndrome, and what Little syndrome is it's a congenital metabolic alkalosis. And if you want to know more about that, just look at the slides on metabolic alkalosis. And what Little syndrome is it's just an overactive ENaC channel, and so what better to do than to inhibit it with a potassium-sparing diuretic. Okay, so carbonic anhydrase inhibitors work at the proximal convoluted tubule. The drug that you most commonly see as a carbonic anhydrase inhibitor is acetazolamide. And we very, very rarely, if ever, use this for hypertension. It's more used for intracranial hypertension. It can also be used for glaucoma, but none of these have to do anything with the kidneys. So I wouldn't worry about seeing this with hypertension, but what you should know is, one, that it works at the kidneys, it works at the proximal convoluted tubule, and what it does is it prevents CO2 and H2O, both of which freely go into the proximal convoluted tubule cell. It prevents that from going to H2CO3. H2CO3 degrades into a hydrogen ion, which goes back into the lumen, and bicarb, which is pulled into blood. Now, if you inhibit CO2 and H2O to going to carbonic acid, or H2CO3, you're going to reduce the amount of, one, acid going into the blood, yes, but you're going to reduce the amount of bicarb going into the blood. Therefore, you can cause a metabolic acidosis. And so the number one adverse effect of acetazolamide or any of the carbonic anhydrase inhibitors is metabolic acidosis. And like any metabolic acidosis, hyperkalemia can precipitate. Remember that hyperkalemia can precipitate from metabolic acidosis or vice versa, and hypokalemia can precipitate from metabolic alkalosis or vice versa. So the ACE inhibitors are a wide range of drugs which are commonly prescribed, and the reason that they're commonly prescribed is that they're renally protective. And examples include lisinopril, enalapril, and captopril. The way these drugs work is that they block conversion of angiotensin 1 to angiotensin 2, which is necessary ultimately to get aldosterone affecting the kidneys. So these are particularly used in patients that are diagnosed with hypertension that also have evidence of renal disease. So patients who are newly diagnosed with hypertension, but they also have diabetes, or they also have some other chronic renal disease, or they have a urine sample and it comes positive for microalbuminuria. ACE inhibitors are useful in these patients because they're renally protective, so they're often used in adjunct to something like a thiazide diuretic. And actually, they do make a drug that's hydrochlorothiazide and lisinopril combined into the same pill. So that's how common they're used in adjunct. You can also see these used in chronic kidney disease, particularly in the glomerulonephritis, just because they preserve renal function. The adverse effects from ACE inhibitors, and you're going to see this most commonly, is cough. So a lot of people, it's still a minority, but a lot of people, a sizable minority, develop cough from their ACE inhibitors, and that just has to do with how the ACE inhibitor affects something called bradykinin, which is not necessary to know for the USMLE, but it's more step 1 material, but it does result in irritation of the lung. So it doesn't do anything else to the lung other than cause a cough. The cough in and of itself is not problematic, but it's irritating to the patient. And so if a patient has a cough and it's affecting their compliance with ACE inhibitors, you can switch them to angiotensin receptor blockers. ACE inhibitors can cause allergic effects such as angioedema. That's also obviously an absolute contraindication for the ACE inhibitors. In that case, you'd want to switch to a different drug, probably, like I said, the angiotensin receptor blockers. The contraindications for ACE inhibitors, and you're going to see this a lot on the USMLE, is bilateral renal artery stenosis. So if a patient has bilateral renal artery stenosis, we never use an ACE inhibitor. We also never use an ACE inhibitor in a pregnant patient. ACE inhibitors tend not to work as well in black patients. So in black patients, when we would normally use an ACE inhibitor, we usually just go right to an angiotensin receptor blocker. And that's a good conduit into the angiotensin receptor blockers. So these kind of work the same way that ACE inhibitors work. Remember that ACE inhibitors block angiotensin 1 to angiotensin 2. What angiotensin receptor blockers do are they just inhibit angiotensin 2 from working. So they just inhibit a different pathway or a different step on the same pathway. So examples of angiotensin receptor blockers are anything that end in artin or sartan. So losartan, valsartan, and candesartan are 3 examples. So these are particularly used, as I mentioned, in patients that you would use ACE inhibitors in that either cannot tolerate it because of the cough or that are black. There are very few adverse effects of the angiotensin receptor blockers, but please remember to never use angiotensin receptor blockers in pregnant patients. So beta blockers are very commonly used. The ones you're going to most commonly see are metoprolol, atenolol, propranolol, and labetalol, which also happens to be a mixed alpha and beta blocker. So these are especially used in patients that are diagnosed with hypertension who have a history of MI or congestive heart failure. More commonly, you're going to start a patient on a beta blocker that has a history of hypertension after they have had an MI. So, but either way, they can also be used in certain arrhythmias, particularly supraventricular tachycardia, and propranolol is often used in essential tremor and in performance anxiety. And of course, that has nothing to do with nephrology, but I figured I'd put that in there because that's something that you could still see on the USMLE. Adverse effect here is bronchospasm, fatigue, and disturbances in lipids. So when I mean lipids, I mean LDL, HDL, VLDL, and so forth. So because it can cause bronchospasm, you don't want to use beta blockers, or you want to avoid using beta blockers in asthmatics or patients with COPD. But if you really, really have to, you can. But definitely not your first or even second line of choice. You want to avoid this at all costs. One thing that I really want to get across here is to never use beta blockers to lower blood pressure in patients with suspected pheochromocytoma. So we don't ever use beta blockers in patients with pheochromocytoma. The only exception would be labetalol, and that's just because it's a mixed alpha and beta blocker. So it doesn't really fit the category of beta blocker, doesn't really fit the category of alpha blocker. It's kind of like a combination. So we can use that one, but you'd never use a pure beta blocker. You'd never use metoprolol, atenolol, propranolol, or any other beta blocker besides labetalol in a patient where you suspect pheochromocytoma and you're trying to lower the blood pressure. So alpha blockers include prazosin, doxazosin, terazosin, and phenoxybenzamine, and these are used to lower the blood pressure in patients where you suspect pheochromocytoma. So phenoxybenzamine is the alpha blocker usually of choice, but you can also use labetalol. That is an acceptable choice. These are also used in benign prostatic hypertrophy, particularly doxazosin and terazosin. The adverse effect from alpha blockers is syncope. And that's usually just the first dose effect. So just make sure that if you give the patient an alpha blocker and you're sending them home and they're going to use it for the first time at home, just make sure that they know that they can develop postural syncope. So if they stand up, they may fall down. Make sure they know that so that they've got somebody with them and that they're aware that this is a possibility. Just something to do in deference to your patient. There's no significant contraindications here. The calcium channel blockers are drugs like verapamil, nifedipine, amlodipine, and diltiazem, and these are used quite often in treating hypertension, but particularly they have a place in treating pregnant women because they have no teratogenic effect. CCBs are also used because they're vasodilators, so they're used in angina pectoris and in esophageal spasms. Again, the adverse effect here is syncope, so make sure that you afford your patient the benefit of a warning before you give them these drugs. And definitely you want to avoid using calcium channel blockers in patients with arrhythmias and with congestive heart failure, in which case you'd want to use the beta blockers. So treating hypertension in the pregnant patient, so anytime a patient has hypertension in pregnancy, you should be looking for the underlying cause. So four of the things that you would think about would be, any of the eclampsia diseases, so preeclampsia, which is hypertension, proteinuria, and edema. Severe preeclampsia, which would be severe enough hypertension, proteinuria, and edema, or just preeclampsia with neurologic symptoms. Eclampsia, which would be preeclampsia or severe preeclampsia along with a seizure. And HELP syndrome, which is high liver enzymes, hemolysis, and low platelets. So these are patients that have had preeclampsia, and now they've developed evidence of hemolysis. They've got disturbed liver enzymes on their metabolic panel, and they've got thrombocytopenia, either symptoms of it or a low platelet count or reducing platelet count on their CBC. So that's just primarily where you're going to see hypertension in the pregnant patient. You could also see essential hypertension in a pregnant patient, a patient who had hypertension before and now she got pregnant. But what's really important is that you know how to treat a pregnant patient who has hypertension, because it's not the same as you're going to treat a patient with hypertension in general. So I'm not going to talk about the underlying causes of these specific OBGYN disorders, but what I will talk about is that in a patient who is pregnant with hypertension, regardless of whether she developed the hypertension during pregnancy or she had the hypertension before and has now gotten pregnant, you want to use hydralazine, you can use alpha-methyl-dopa, or you can use any of the calcium channel blockers. But particularly hydralazine or alpha-methyl-dopa. So the best way to think about it is use those three. Okay, use any of those three: hydralazine, alpha-methyl-dopa, or any of the CCBs. One of those will be the right choice. Everything else, stay away from it. Definitely stay away from diuretics. Definitely stay away from ACE inhibitors. Definitely stay away from angiotensin receptor blockers. They're never okay to use in pregnancy. Otherwise, hydralazine and alpha-methyl-dopa are okay. And one thing that I didn't put in here that's important when you have a hypertensive crisis, so a patient with extremely high blood pressure or neurologic symptoms coexisting with the hypertension, or a patient with hypertension that also has changes on the fundoscopic exam, you would want to use sodium nitroprusside IV. And for more information on that, you can check the hypertension slides. So that is all I have. That is a brief but relatively comprehensive overview of hypertension drugs.